Hello everyone, myself Neha Kasurde studying in the second year B Pharmacy in Shivajirao West Jondhale College of Pharmacy. Today I am going to explain about the topic anti-epileptics under the guidance of Dr. Nitin Moire sir, professor and principal of our college. Here are some facts about anti-epileptic drugs. Anti-epileptic drugs should have good oral absorption and bioavailability. It is most metabolized in liver but some excreted unchanged in kidney. Because of overlapping mechanism of action, best drug can be chosen based on minimizing side effects in addition to efficacy. Add-on therapy is used when a single drug does not completely control seizures. Classic anti-epileptic drugs generally have more severe CNS sedation than the newer drugs except ethosuximide. The mechanism of action of anti-epileptic drugs. There are three main mechanisms of action. First one is enhancement of gamma-aminobutyric acid, which is the predominant inhibitory neurotransmitter in the mammalian central nervous system. Second is the inhibition of sodium channel function, and third one is inhibition of calcium channel function. Some other mechanisms include inhibition of glutamate release and second block of glutamate receptors. Classification of anti-epileptics. Anti-epileptic drugs are classified into two groups, which is the classical drugs and newer drugs. The classical drugs includes phenytoin, phenobarbital, primidone, carbamazepine, ethosuximide, valproate, and trimethendione, while newer drugs includes lamotrigine, felbamate, topiramate, gabapentin, tiagabine, vigabatrin, and phenobarbital. Here are some first line drugs which are used for the specific type of epilepsy. Carbamazepine is used for the partial or secondary generalized tonic-clonic seizures. Valproate is used for the tonic-clonic seizures. Ethosuximide is used in the absence seizures. Valproate is used for the myoclonic seizures. ACTH or prednisolone is used in the infantile spasms. Diazepam is used for the status epilepsy. Mechanism of action of anti-epileptic drugs. Phenytoin, carbamazepine, felbamate, lamotrigine and valproic acid blocks voltage-dependent sodium channels at the high firing frequencies. Then the barbiturates, which prolongs the gamma-aminobutyric acids mediated chloride channel openings. Third one is the benzodiazepines, increases frequency of the gamma-aminobutyric acid mediated chloride channel openings. Fourth is the valproate, which enhances gamma-aminobutyric acid transmission in the specific circuits, then blocks voltage-dependent sodium channels, and after that blocks T-type calcium currents. Fifth one is the ethosuximide, blocks slow threshold transient T-type calcium channels in the thalamic neurons. Mechanism of action of the newer anti-epileptic drugs. First one is the vigabatrin. It is irreversibly inhibits gamma-aminobutyric acid transaminase. Second is the tiagabine. It interferes with the gamma-aminobutyric acid reuptake. Third one is the topiramate. It blocks voltage-dependent sodium channels at the high firing frequencies, then increases frequency at which the gamma-aminobutyric acid opens chloride channels, then antagonized glutamate actions at the receptor subtype. Fourth one is the gabapentin. It modulates amino acid transport into the brain and may interfere with the gamma-aminobutyric acid reuptake. Phenobarbital. It is gamma-aminobutyric acid facilitatory and gamma-aminobutyric acid mimetic agent. The adverse effects of the phenobarbital are as follows. First is the sedative action. Second, long-term administration causes behavioral abnormalities, impairment of learning and memory hyperactivity in the children, and mental confusion in older people. Rashes, megaloblastic anemia and osteomalacia causes on the prolonged youth. The uses and indications of the phenobarbital are as follows. First is the generalized tonic-clonic GTC simple, partial SP and complex partial CP seizures. Take 60 mg 1 to 3 times a day in adults and in children 3 to 6 mg per kg per day. Status epilepticus may be injected intramuscular or intravenous, but response is slow to develop, not effective in the absence of seizures. Phenytoin, which is also known as the diphenylhydantoin, it is most commonly used drug. Phenytoin prolongs the inactivated stage of the voltage sensitive neuronal in a plus channel and reduces the neuronal excitability. The pharmacokinetics of the phenytoin are as follows. First, it is highly bound to the plasma proteins. Absorption is formulation dependent. The kinetic changes from the first order to zero order over the therapeutic range. Small increment in those produce disproportionality high plasma concentrations. Then the first phenytoin is taken through the intravenous or intramuscular routes. The adverse effects of the phenytoin: gum hypertrophy, hirsutism, megaloblastic anemia, osteomalacia, hyperglycemia, and hypersensitivity reactions. The uses of the phenytoin are as follows: generalized tonic-clonic simple and complex partial seizures. It is ineffective in absent seizures. Dose 100 mg BD, maximum 400 mg per day in children and 5 to 8 mg per kg per day. Next drug, carbamazepine. The adverse effects of carbamazepine are as follows: dose related neurotoxicity, which causes sedation, dizziness, vertigo, diplomia, and ataxia, vomiting and diarrhea, acute intoxication, coma, convulsions, and cardiovascular collapse, hypersensitivity reactions, rashes, photosensitivity hepatitis, lupus like syndrome, water retention, and hyponatremia in the elderly as it enhances ADH action. Uses of the carbamazepine are: it is the most effective drug for CPS and first choice drug with the affinity for GTC and SPS. Ethosuximide, it inhibits T-type Ca+2 current in the thalamic neurons. The adverse effects of the ethosuximide are GI intolerance, tiredness, mood changes, agitation, headache, drowsiness, and inability to concentrate. Uses: it is only in absent seizures, but use has now declined as many consider valproic acid to be superior to it. Lamotrigine, it blocks sodium as well as high voltage dependent calcium channels. Uses: it uses as a broad spectrum antiepileptic, refractory cases of partial seizures and GTCS, absence and myoclonic or akinetic epilepsy, Lennox-Gastaut syndrome. The adverse effects of the lamotrigine are sleepiness, dizziness, diplopia, and vomiting, better tolerated than the carbamazepine or phenytoin. Rash may be a saver. Next anti-epileptic drug is tiagabine. Recently developed anticonvulsant potentiates gamma aminobutyric acid mediated neuronal inhibition by depressing gamma aminobutyric acid transporter GAT1, which removes synaptically released gamma aminobutyric acid into neurons and glial cells. Uses: add-on therapy of partial seizures with or without secondary generalization. Adverse effects: mild sedation, nervousness, asthenia, amnesia, and abdominal pain. Here are some reference links. We are thankful to our President Honorable Dr. Shivajirao Zondre Sir, Secretary Honorable Dr. Geeta Khare Ma'am, and Principal Dr. Nitin Moire Sir for encouragement and guidance for efficient use of social media to spread knowledge through making informative videos. Please like and subscribe our channel for such informative videos. Thank you.